Good morning everyone. Welcome to this recall session of INI-CET. We are going to discuss the surgery questions. So the questions discussed here are recall based, and motive of this live session is to get the actual questions asked in the exam, and the final questions whatever we are going to receive after the discussion, it will be uploaded on the PrepLadder app. Okay guys, so let's start the questions. First of all, tell me, which of the following is not the component of meant to be? Guys, I'm waiting for your reply. Tell me, which of the following is not the component of meant to be? Clear? So pheochromocytoma is the component, marfanoid features are the component, mucosal neuroma is the component. Parathyroid hyperplasia is a part of meant to A, not meant to be. So it is parathyroid hyperplasia. Dominic, very good Dominic, you are correct. It is parathyroid hyperplasia, which is the part of meant to A, not meant to be. So this is incorrect. Otherwise, pheochromocytoma is the part, marfanoid features is the part, mucosal neuroma is the part. So correct answer for this question, it is A. Clear guys? It is A. Okay. Now see, this is A. So what are the components of meant to be? Can you tell me? Meant to be, it is also known as meant 3. And you know that all men are autosomal dominant. What is the characteristic feature? How to remember? The characteristic feature, you can see MP had 3 MIs. MP had 3 MIs. M, medullary carcinoma thyroid. P, that is pheochromocytoma. M, mucosal neuroma. M, megacolon. M, marfanoid features. I, intestinal ganglioneuroma. I, that is intestinal ganglioneuroma. Clear? So how to remember? Meant to be, it is also known as meant 3. Characteristic feature, MP had 3 MIs. M, medullary carcinoma thyroid. P, pheochromocytoma. P, pheochromocytoma. M, mucosal neuroma. Megacolon, marfanoid features, and intestinal ganglioneuroma. Got it? So this is very, very important. Meant syndrome, this is meant to be or meant 3. Next, easy question guys. Tell me what is the correct answer. Breast cancer case. Can you tell me the size? 6 into 7 centimeter. Size 6 into 7 centimeter. Invading pectoralis major and ipsilateral what? Matted axillary nodes. Along with that, there is dimpling. Dimpling belongs to which of the following category? Let me see who is the genius over here. What is the correct answer? Guys, what is the correct answer? See, important point related to breast cancer staging. Yes, whenever there is dimpling, if there is involvement of nipple retraction, nipple deviation, or if there is involvement of pectoralis major or minor, this is not included in staging. It is not going to affect the staging. So involvement of pectoralis major, involvement of pectoralis minor, dimpling, or involvement of dermis alone, changes in the nipple, this is not included in the staging. So can you tell me, if the size is more than 5 centimeter, if the tumor size more than 5 centimeter, what's the stage? You know T1 up to 2 centimeter, you know T2 more than 2 to 5 centimeter, and can you see T3 that is more than 5 centimeter. Yes, so let me see. Yes, Dr. Mohit Parmar, Shailesh, Sudarshan, Sudip Shah, Dr. Khan. So guys, it is T3 because the size is more than 5 centimeter. After that, important point, matted axillary lymph node. And you know that whenever there is matted axillary lymph node, this is N2A. So it is T3 N2A. So what is the correct answer guys? It is T3 N2. So correct answer, that is T3 N2. Tawfiq Hassan, let me see how many of you were correct. Dominic is correct, Sudeep Saha, Mohit Parmar, Dr. Khan, all of you are correct guys. So majority of you marked what? T3 and 2. So correct answer guys, it is T3 and 2, right? Breast cancer staging is the most important topic out of all 19 subjects. I'm telling you, every year minimum 1 or sometimes 2 questions are asked directly or indirectly from breast cancer staging. So let's discuss quickly the breast cancer staging. Let's discuss quickly. You know T1. What is T1? When the size is up to 2 centimeter. T2 more than 2 to 5. T3 more than 5. Most important is T4A. T4A. A means अंदर. जब अंदर वाले स्ट्रक्चर इन्वॉल्व हो जाएंगे, that is T4A. A अंदर. So you can see T4A अंदर. Clear? Under means breast के अंदर क्या है? Chest wall. Behind the breast there is chest wall. So if there is involvement of chest wall, and you know, chest wall is formed by ribs plus intercostal muscles plus serratus anterior. Very important point. Pectoralis major, pectoralis minor is not the part of chest wall. Clear? After that T4B, B means bahar, T4B that is bahar, bahar matlab breast ke bahar, skin ka involvement. So if skin changes are there, skin changes like there is ulceration, there is edema including pudy orange, satellite nodules. What is T4C? Guys, it is both T4A plus T4B, and you know if it is T4D, that is inflammatory breast cancer. Important point which examiner asked, can you see here? What? That involvement of dermis alone, involvement of pectoralis major minor, nipple retraction deviation, these are not included in T4. Involvement of dermis alone, involvement of pectoralis major minor, nipple retraction deviation, not included in T4. So here dimpling is there, this is not included in the staging. What is the stage? T3 and 2. So here this is T staging, guys. See the lymph node staging. It is N1. What is N1? You can see N1. Whenever there is metastasis to ipsilateral axillary lymph node, which level? 1 and 2, and it should be mobile. Most important, it should be mobile. And whenever it is fixed or matted, same lymph node, if it is fixed or matted, it is N2A. If it's clinically apparent internal mammary nodes, N2B. What is N3A? Infraclavicular, N3B. Axillary plus internal mammary, N3C. Involvement of supraclavicular lymph node. And whenever there is no metastasis, it is M0, metastasis, it is M1. No distant metastasis, M0, M1 distant metastasis. So I am repeating again, this is most important topic. Almost every year in each and every paper you are going to get at least one or sometimes two questions from breast cancer staging. Clear, guys? So what is the correct answer? It was T3 and 2. T3 and 2. Next, easy question. Tell me, what is the correct answer? I am waiting for your reply. 40 years old female. There is history of prior neck irradiation, diagnosed with papillary carcinoma thyroid. Can you tell me the treatment of choice? Treatment of choice. Shailesh, very good Shailesh. Treatment of choice. Shailesh, yes. Tawfiq Hassan, very good Tawfiq. Tawfiq, you are correct. Yes. Now see guys, you know that low dose radiation exposure during childhood increases the risk of papillary carcinoma. What are the other two risk factors which are going to increase the risk of papillary carcinoma? Tell me. It is thyroglossal cyst. Other risk factors which are going to increase the risk, one is thyroglossal cyst and another Hashimoto's thyroiditis. It is Hashimoto's. So thyroglossal cyst and Hashimoto's thyroiditis, it is going to increase the risk. Right? You know that it is seen in young females 3rd to 4th decade. If papillary carcinoma thyroid is there, what you do? You go for total thyroidectomy. You do removal of enlarged central group of lymph nodes. MRND is only done. MRND is modified radical neck dissection. MRND is only done whenever there is positive lymph node. Can you see in the question? Yes, there is no involvement of lymph node. It is not mentioned. Clear? Clear? So MRND is only done when lymph node is positive. So you can see here, hemithyroidectomy, it is done for benign disorder. MRND, hemithyroidectomy, this is incorrect. So we have to choose between B and D. Since lymph node is not involved, if lymph node is not involved, this MRND should not be done. So obviously what's the correct answer? Correct answer is total thyroidectomy. So correct answer is total thyroidectomy. Khinu, Shobhit, all of you are correct, guys. It is total thyroidectomy. And suppose it is also mentioned that apart from papillary carcinoma thyroid, there is involvement of lateral cervical lymph node. In that case, we would have gone for MRND. Got it? So correct answer, since lymph node is not involved here, we go for total thyroidectomy. Okay, guys? Correct answer, total thyroidectomy. Anybody wants to add something in the question? Shobhit, Khinu, Dr. Sudarshan, Khurshid, anybody wants to add something in the question? Shakti? So everybody is correct. Majority of you marked option B, total thyroidectomy. Clear? Guys, I am telling you again, papillary carcinoma and follicular carcinoma, these are two favorite malignancies of AIMS people, INI-CET people. Almost every year, sometimes they ask papillary, they give that orphan NEI nuclei, and sometimes they give follicular carcinoma and they ask FNAC is not able to differentiate follicular adenoma from follicular carcinoma. Got it? So these are the two questions which are asked on the basis of, alternate years they are asking these questions. Okay, next. This is very important and I am telling you it's a repeat question. Which of the following is not a part of primary survey? Let me see how many of you are going to mark the correct answer. Which of the following is not the part of primary survey? Guys, what is primary survey? According to ATLS protocol, there is primary survey, there is secondary survey. Primary survey means A, B, C, D, E. What is primary survey? It's managing the acute life-threatening situation. So, in primary survey, we are going to manage the life-threatening situations. It means the investigations which are done in primary survey, it can be done bedside. Any investigation which can be done bedside, only those investigations are included. The investigation which cannot be done bedside, these investigations are not included. Let me see. Yes, very good. Muhammad Anas, Khurshid, Bhavnesh Chavan, Shobhit, Dr. Khan, Paresh Chaudhary, Aditya Sharma, guys, everybody is correct. Okay, so you know, in primary survey, imagine because of trauma, patient is having hemothorax. Yes, how to make the diagnosis? Patient is having pneumothorax. How to make the diagnosis? Chest X-ray, PA view. So, chest X-ray, PA view. Suppose patient is having hemoperitoneum. If the patient is having hemoperitoneum, collection of fluid, collection of blood in peritoneal cavity, what? We go for fast or E-fast, extended fast, or fast means ultrasound. And if retroperitoneal hematoma is there, retroperitoneal hematoma mainly because of pelvic fracture. So, how to rule out pelvic fracture or how to make the diagnosis of pelvic fracture, guys, tell me? We go for X-ray pelvis AP view. So, 3 investigations which are used in primary survey: fast, pelvic X-ray, X-ray pelvis. Which view? This view you have to remember, AP view, and chest X-ray PA view. Chest X-ray PA view. Clear? CT is not the part of primary survey. CT is not the part of primary survey. Clear? Right? Next question, guys. Yes, next question. 2 most important X-ray in trauma patient. 2 most important X-ray in trauma patient, that is pelvic X-ray. So, X-ray pelvis AP view, chest X-ray PA view, these are the 2 most important X-rays. Actually speaking, this is a repeat question. It was asked previously also and we discussed in the video lectures also, in the notes also many times. What? In primary survey, what are the investigations done? Guys, we discussed just now. Investigations done, chest X-ray PA view to evaluate thoracic blood loss, X-ray pelvis AP view to identify pelvic fracture, fast evaluation of abdomen, and I have mentioned specifically CECT, it's not the part. CECT is not done in primary survey. What are the 2 most important X-rays done? We discussed chest X-ray PA view, chest X-ray PA view, and X-ray pelvis AP view. Okay, right. So, somebody is mentioning, Shailesh and Mohit wants to say that, sir, X-ray pelvis AP view was given. Yes, usually this is the complete option. They give chest X-ray PA view, X-ray pelvis AP view. So, X-ray pelvis AP view. I am repeating again, this is very, very important. X-rays or investigations done in primary survey, these investigation can be done bedside. So, chest X-ray PA view, X-ray pelvis AP view, and what else? Fast. Clear, guys? Fast. Next. Very easy question. Let me see who is the genius over here. Patient was brought to trauma unit after chest trauma. What's the problem? Chest trauma. Chief complaints of breathlessness. After further examination, systolic blood pressure, can you see? Patient is having hypotension. GCS less than 8, less than equal to 8 means severe head injury patient is having. Auscultation, breath sounds are absent. Guys, chest trauma, breathlessness, hypotension, breath sounds are absent. What is the next best step? Clear? GCS is less than 8. Tell me. Yes, very good. Majority, Tausif, Prakash, Shobhit, Shailesh, Khurshid, Sudipta. Yes, very good. Bhavnesh, Sudarshan, Najire, all of you are correct, guys. Let me tell you. What are the components of primary survey? We follow A, B, C, D, E. So, it is cervical spine protection followed by airway, breathing, circulation, disability and exposure. In airway, what? Airway maintenance after cervical spine protection. What is a big problem? Any patient who is not able to speak, any patient who is having maxillofacial trauma, noisy breathing, GCS less than 8, first secure the airway. This patient is having absent breath sounds, breathlessness, low BP. It means chances are that the patient is having what? Tension pneumothorax. Yes, let's make the diagnosis. Absent breath sounds, hypotension, breathlessness, tension pneumothorax, GCS less than 8. What? Patient is having severe head injury. Patient is having severe head injury. So, first secure the airway. Secure the airway and then what? ICD placement. So, what is the correct answer here, guys? Secure the airway, ICD placement. X-ray, don't send the patient. You don't have time. Patient might die in radiology department. Send for CT, send for ultrasound. No, immediately what you have to do. Okay, Dr. Babu Bhai wants to say that, sir, SpO2 was also there. SpO2 was kitna? SpO2 was 85%. So, you can see here saturation is also lesser. So, in this case first secure the airway and after that go for ICD placement. Clear? This is very important, guys. Let us discuss what's the protocol we follow. In primary survey we follow ABCDE. We discussed that first priority it is cervical spine followed by airway. That is the first priority. So, in all trauma patients cervical spine injury should be suspected. So, first step cervical spine stabilization. After that we have to assess the patency. How to assess the patency? Ask the patient's name. Any patient who is able to speak, if you can elicit the verbal response, it means what? Airway is patent. And if patient is not able to speak, or why patient is not able to speak? If there is because of obstruction of airway, mental status depression, or if there is noisy breathing, facial trauma, and can you see here GCS less than equal to 8. All these cases require what? Airway management. So, guys, all these cases require airway management. And what is the stepwise progression? Clear the airway, chin lift, jaw thrust, insertion of oropharyngeal airway. What is the definitive airway of choice? We insert oral endotracheal intubation with cuffed ET tube. So, it is the oral endotracheal intubation. It is the oral endotracheal intubation with cuffed ET tube. Clear? So, this is primary survey. Next, guys, this question was asked in the last exam also, and this was asked many times in NEET PG as well as INI-CET. Let me see how many of you are going to mark the correct answer. Post-gastrectomy, patient came with complaint of lower limb weakness. What would be the likely cause? Let me see. Everybody, Moinuddin, Khurshid, Ritesh, Aga, Shafiq, Dr. Khan, all of you are correct, guys. Everybody is correct. Aditya, Priyanka Kaur, Mohammad Shaf, all of you are correct. You know that whenever you perform gastrectomy and more than 50% of stomach is removed, what is the problem? There is intrinsic factor deficiency, and if there is intrinsic factor deficiency, it is not going to bind with vitamin B12, and this complex is not absorbed, means not absorbed in terminal ileum. So, whenever more than 50% of stomach is removed, patient will be having vitamin B12 deficiency. Clear? So, what kind of anemia patient is going to develop? Obviously, guys, megaloblastic anemia. So, these patients are going to develop megaloblastic anemia. Clear? So, these patients are going to develop megaloblastic anemia. Clear? This was asked many times. Correct answer is A. Suppose I am asking one simple question. Yes, what is the most common metabolic complication after gastrectomy? Tell me. Tell me in the chat box, guys. Most common metabolic complication after gastrectomy. Okay, Aditya wants to say that history of difficulty in balance was also there. There was history of difficulty in balance. History of difficulty in balance. Clear? So, there was history of difficulty in balance. Okay. Can you tell me what is the most common metabolic complication after gastrectomy? Yes, iron deficiency anemia, because because of gastrectomy there is decreased acid production, Fe3 plus, it is converted into Fe2 plus because of acid. You know that this is oral form, this is absorbable form. So, if lesser amount of Fe3 plus is converted into Fe2 plus, what will be the problem, guys? Yes, iron deficiency anemia. So, that is why you have to read the question carefully. Is the most common metabolic complication, or if neurological symptoms are there, it is because of what? Vitamin B12 deficiency. Clear? So, let us discuss quickly metabolic complications of gastrectomy. Yes, the most common metabolic complication we discussed, iron deficiency anemia, because Fe3 plus oral form, Fe2 plus absorbable form, with the help of acid it is converted. So, whenever patient is having iron deficiency anemia, you have to give what kind of supplementation, tell me? Oral supplementation. So, increased oral supplementation, in which case you will find megaloblastic anemia. Megaloblastic anemia when 50% of stomach is removed, and in this case what you have to give, guys? You have to give lifelong parenteral supplementation. Clear? So, it is lifelong parenteral supplementation. I am repeating again, it is very important. Chances are there that you are going to get similar question in FMG and NEET PG. Clear? Next. Easiest question, guys, tell me what is the correct answer. Let me see who is going to mark the correct answer. Which of the following is most common symptom of carcinoma esophagus? Easiest question. Let me see who is going to reply correctly. Yes, very good. Mohim, Shailesh, Moinuddin, Tawfiq, Aga, Adit, Muhammad, Anas, Shobhit, Ritesh, Serotonin, Bhavesh, all of you are correct. Easy question. See, you know, guys, this is the esophagus, this is the stomach. You got it? Now, where is the malignancy? Here. You can see here. This is the malignancy. This is the malignancy. So, because of this malignancy, what happens? The growth is inside the lumen. Over a period of time, the lumen is compromised. So, initially patient will be having dysphagia, and dysphagia move to solids followed by liquids, solids followed by semi-solids followed by liquids. So, you can see what kind of dysphagia patient will be having, you know, it is progressive. What kind of dysphagia, guys? It is progressive dysphagia. So, progressive dysphagia. So, initially to solids followed by semi-solids followed by liquids. Clear? So, what is the correct answer? Dysphagia move to solids. Yes, dysphagia move to solids. Can you tell me in which condition there is dysphagia move to liquids? I am waiting for your reply. Dysphagia move to liquids. Yes, achalasia cardia, guys, you know that in achalasia cardia, dysphagia move to liquid. Clear? So, move to liquids. How to remember? In achalasia you can see L comes first, there is first L then S. So, L first, else before S. So, liquid followed by solids. So, in achalasia dysphagia move to liquids, in carcinoma esophagus dysphagia move to solids. Clear, guys? Clear? So, this is the question. Now, what is the problem? We discussed already many times in the lectures, in the notes. You can see the most common symptom, dysphagia followed by weight loss, and it is moved to solids followed by semi-solids followed by liquids. Clear? So, dysphagia, what kind of dysphagia we discussed? Progressive dysphagia. It is progressive dysphagia. Clear? Next. Easiest question, guys. Tell me, this was asked many times in the exam. Many times. Okay, this time direct question was not there. There was a language. So, this language was there. Tell me what is the correct answer. Young male presented to you with complaint of pain in iliac fossa, left iliac and lumbar region, stabbing in nature. Patient reveals his history of occasional hematuria. Best imaging technique. First, you tell me what is the diagnosis. Lumbar region pain, iliac fossa pain, left side, stabbing pain, occasional history of hematuria, best imaging investigation. First, tell me, guys, what is the diagnosis. Very good, Shailesh, Ganesh, Moinuddin, Shobhit, Aditya, Serotonin, Priyanka, everybody is correct. Pain, stabbing, occasional history of hematuria, location lumbar region, iliac fossa. Guys, it is ureteric calculus. Can you tell me what is the location? Ureteric stone. If pain radiates to iliac fossa, it means it is in middle 1/3. It is located in middle 1/3, and you know that for ureteric calculus or for ureteric colic, what is the investigation of choice? Since 90% of kidney stones are radio opaque, we go for CT. What kind of CT we go for? NC-CT. So, non-contrast spiral CT. So, non-contrast CT, including which region? KUB, that is kidney ureter bladder. So, this is non-contrast spiral CT. This is non-contrast spiral CT. Okay, Shailesh wants to say that कि sir question में mention था ureteric stone. So, that's easy. Yes, अगर question में mention था that ureteric stone is there, it's very easy. So, what? Non-contrast spiral CT. Okay, one option was ureteroscopy. So, one option was ureteroscopy. Obviously, ureteroscopy is not investigation of choice. If you want to manage ureteric stone, you want to take it out, then you can go for URS or ureteroscopy. So, what is the correct answer, guys? C. Correct answer is C. Many times we discuss similar question, right? So, you can see here, when stone is located in middle 1/3, we discussed many times, stone in the middle 1/3, pain radiates to iliac fossa, hypogastrium, groin via iliohypogastric nerve. Clear? Via iliohypogastric nerve, and we discussed what is the investigation done. You can see, guys, the investigation which is done, that is non-contrast spiral CT. It is non-contrast spiral CT. You can see here, this is non-contrast spiral CT. Clear? So, this is non-contrast spiral CT, you can see. Clear? So, that is non-contrast spiral CT. Clear? Next. Okay. Again we discussed this question in inflammatory bowel disease. True love and Witt's classification. Guys, tell me what's the correct answer. True love and Witt's. Saif Abbas wants to ask that, sir, will you conduct a session for FMG also? Yes, yes, guys, in PrepLadder we conduct session for INI-CET, FMG, NEET, PG, for everything. There is LRR for all the exam, before exam, and there is recall session after the exam. We will be conducting a session for FMG also, don't worry. And let me tell you, it's very, very important, because you will see what are the trends of questions which are asked nowadays. Clear? What are the trend of important topics which are asked nowadays? So, true love and Witt's classification. Let me see who is going to mark the correct answer. All of you. Paresh, Khinu, Jakir Khan, Muhammad Anas, Paresh, Khinu, all of you are correct, guys. Let me tell you, nowadays in this modern era, it's very difficult to find true love. But if you have ulcerative colitis, you can easily find true love. Very difficult to find true love, but you can easily find true love if you have ulcerative colitis. So, now I hope you will not forget, ulcerative colitis, easily find true love. You can easily find true love. And what is the true love? It is true love and Witt's classification. Let me tell you, it's a repeat question. It was asked 2-3 times previously also. Let me tell you about this INI-CET exam. This year, most of the surgery questions were repeat question. Most of surgery questions. Only 1 or 2 were new. Rest, most of the questions was repeat. Okay. So, it was severe ulcerative colitis. Somebody wants to say that one option was ARDS. One option was ARDS, okay. One option was ARDS. Correct answer is, it is severe ulcerative colitis. The classification is true love and Witt's classification. Clear, guys? Shailesh Agrawal wants to ask कि sir, urinary bladder stone में भी NCCT आंसर होगा? Guys, question for all of you. मान लीजिए आपके urinary bladder में stone है, which investigation should be done? It's very easy. How many bladders you have? 2. Gallbladder, urinary bladder. How many bladders you have? 2. Gallbladder, urinary bladder. Got it? 2 bladders. For both of these bladder stone, what investigation of choice is same? What? Ultrasound. So, gallbladder stone as well as urinary bladder stone, for both of these investigation of choice is ultrasound. I hope, Shailesh, you will not forget now. Shailesh, tell me. I hope you will not forget now. 2 bladders you have, gallbladder, urinary bladder. For both of these bladder stones, yes, what is the investigation of choice? Ultrasound. Shailesh, is it clear? Clear? So, here it is severe ulcerative colitis. Next, guys. So, we discussed in the notes, in the videos, modified true love Witt's severity index. It is for disease severity grading of ulcerative colitis. So, this is for disease severity grading for ulcerative colitis. Clear? So, how to remember? True love in ulcerative colitis. True love in ulcerative colitis. True love. This is the new question, guys. This question is new. Okay. What is the angle used? Let me see. Angle used during laparoscopic working port and telescope. Working port and telescope. Let me discuss first the angle. Okay, azimuth angle, elevation angle, working angle, manipulation angle. Let me discuss first, because this is a new question. First, see, this is azimuth angle. You can see here azimuth angle. So, this azimuth angle, it is the angle between one instrument and the optical axis of endoscope. You can see this is the endoscope optical axis, this one. This is the endoscope optical axis, and you can see this is the instrument. This one is instrument. clear. So, instrument, this is azimuth angle, clear. After that you can see this is the manipulation angle, it is angle between manipulation. So, you are going to manipulate with two working ports instruments. So, this is ideally 60 degree, this is manipulation angle, angle between two working ports. So, you can see these are working ports, that is manipulation, you are going to manipulate, and then elevation angle, you can see this is the horizontal plane. So, there is elevation angle, angle between instrument and horizontal plane, and again it is 60 degree. So, this is 60 degree, horizontal plane and instrument, this is elevation angle, clear. So, see the question guys, see the question, it's easy to understand. So, angle between laparoscopic working port and telescope means the optical axis. So, obviously it is azimuth angle, this is azimuth angle, working angle between two ports, elevation angle, horizontal axis and the port, clear guys. So, correct answer, it is azimuth angle. Okay. This was the new question, it was asked for the first time. Chances are that in future they might ask the questions. So, you should know azimuth angle, angle between optical axis of endoscope and instrument, between two working ports, angle is manipulation, and elevation, angle between horizontal plane and the instrument. Majority of cases you can see here manipulation and elevation angle, both of these are 60. Aditya Sharma wants to say that sir ye wala attempt nahi kiya. Obviously guys, majority of students must not be knowing the answer, right. So, अच्छा कि आपने attempt नहीं किया, because if you don't know the topic, obviously there are chances that you are going to mark the incorrect answer. Okay. Shailesh also wants to say that मैंने भी नहीं किया. कोई बात नहीं guys, कोई बात नहीं, 1-2 questions doesn't matter. This is new for everybody, Repeat question गलत नहीं होना चाहिए, that's most important. Okay. Next, let me tell you nowadays what is the trend of questions. If you see 2-3 questions I am telling you, these are asked in each and every paper. First, tension pneumothorax, second, pressure sore, pressure ulcer, third, Fournier's gangrene, clear. These are the questions which are asked in each and every paper. Fifth, perforation peritonitis, gas under diaphragm, pneumoperitoneum. So, guys, this pressure sore, pressure ulcer, it is very important. see the question. Patient was bedridden after his neurosurgery. Routine examination following lesion is seen as shown in the image given below. What is the grading in this case? Okay, right. Burns also, yes. So, guys, first let me tell you the grading of burns. Clear? It's very easy. Grading of burns first, so that you are going to understand everything. Grading of burns. It's very easy to understand. Clear? Grading of burns. And let me tell you, there is no difference between grading of burns, means degree of burns, and grading of pressure sore or pressure ulcer. It's very easy, no difference. Let's discuss. What is first degree burn? Yes, epidermal burn. What is second degree burn? Whenever there is epidermis involvement, apart from that there is involvement of dermis. What is third degree burn? When there is involvement of what? This subcutaneous fat. Third degree burn. What is fourth degree burn? Apart from full thickness skin loss, there is involvement of underlying structure like muscle, bone or brain. So, first degree epidermis. So, in grade 1 pressure sore or pressure ulcer, there is erythema, there is involvement of only epidermis. In second degree, there is involvement of epidermis plus dermis. In grade 2 pressure sore or pressure ulcer, there is partial thickness skin loss with involvement of epidermis and dermis. Third degree burn, there is involvement of subcutaneous fat. Grade 3 pressure ulcer, there is full thickness skin loss, involvement of epidermis, dermis plus subcutaneous tissue. Fourth degree burn, apart from full thickness skin loss, there is involvement of underlying structure, muscle, bone, brain. Grade 4 pressure sore, full thickness skin loss plus involvement of underlying muscle or bone. Guys, so it is same, okay. So, see in this image what you can see, in the image you can see that there is involvement of what? Epidermis plus dermis, clear, involvement of epidermis plus dermis, clear. So, obviously it is grade 2. I am repeating again, similar question will be asked in INI-CET in the coming FMG and NEET PG exam. So, let us discuss quickly. What is stage 1 or grade 1? early superficial ulcer, there is erythema of skin, there is only involvement of epidermis. Clear? Grade 2. In the grade 2, you can see partial thickness skin loss including epidermis plus dermis. This is partial thickness skin loss. Stage 3, here full thickness skin loss, involvement of subcutaneous tissue. Clear, guys? And what is stage 4? You can see in stage 4, there is full thickness skin loss plus involvement of muscle, bone, joint, tendon. In majority of exams, in most of the cases, okay, somebody is saying that, sir, partial thickness skin loss was written. So, if partial thickness skin loss was written, obviously it is grade 2 or stage 2. Let me tell you, in most of the exams they are asking which question? They are asking stage 4, where sacrum is exposed. Sacrum is exposed, underlying muscle is exposed. Clear, guys? So, I hope you will not forget now. I hope you will not forget now the burn degree and the pressure sore grade, it is almost same. So, let us discuss the question again. Yes, Gandhar Lalmani wants to say, Lalmani Gandhar wants to say that, sir, partial thickness loss was mentioned. Okay, so guys, it becomes more easy. Yes, if partial thickness skin loss is already mentioned, so partial thickness skin loss is mentioned, partial thickness skin loss, it is already mentioned. Clear? What else? Yes, NEET PG. You remember NEET PG? In the NEET PG, stage 4 was asked. I am telling you. See, pressure sore, pressure ulcer, burn classification, tension pneumothorax, perforation peritonitis, acute pancreatitis, severity staging like Q SOFA, Bishop, Apache 2. All these are favorite questions of examiner. Every year they are asked. These questions are asked. SIRS. These questions are asked. So, this is guys, this is partial thickness skin loss. It is grade 2. Grade 2. Okay. Grade 2. Next, easiest question. This was asked in many exams previously. See, a male mine worker living in urban slum presented to OPD with persistent abdominal pain in right hypochondriac region, which is mild in nature. Hepatomegaly is present, means something is there in the liver. Ultrasound revealed liver cyst, most probably hydatid cyst. Aspiration was clear. Water with some sand like material, high protein content. So, guys, obviously it is hydatid cyst. Causative organisms, all of you know that for hydatid cyst the causative organism is Echinococcus granulosus, and if patient is having malignant hydatidosis, it is Echinococcus multilocularis. So, here the organism is Echinococcus granulosus. Most common organism, that is Echinococcus granulosus. Clear? For malignant hydatidosis, guys, it is for malignant hydatidosis, it is Echinococcus multilocularis. Okay, let me tell you about hydatid cyst. Majority of patients are asymptomatic. There is hepatomegaly. Some patient complains of abdominal pain, abdominal discomfort, and abdominal pain is usually mild. Clear? So, this is Echinococcus. Next, it is based on anatomy, simply anatomy. Tell me, guys, what is the correct answer? Simple anatomy. During separation of spleen from stomach, while performing splenectomy, which of the following artery might be likely source of bleeding? Guys, tell me. You can see this is the anatomy. Where is the spleen? You can see here is the spleen. Clear? Can you tell me what are these vessels? What are these vessels? Yes. Guys, there is very arteries which are very close to stomach and spleen. Can you tell me in the proximal part of stomach, these arteries are there? Short gastric artery. So, guys, this is short gastric. Yes, these are short gastric. These are short gastric arteries. Clear? Short gastric arteries. Clear? So, what? It is the short gastric artery. Short gastric artery. Clear, guys? It is short gastric artery. Okay? So, this is one of the commonly injured artery during splenectomy. Which organ is most commonly injured during splenectomy? Can you tell me? Question for all of you. Okay, somebody wants to ask left gastroepiploic. Guys, left gastroepiploic. This is going to supply the momentum. It's like this. The closest artery which is there in the proximal part of stomach, yes, short gastric, it is short gastric. You know gastric varices, in the gastric varices in the proximal part of stomach, these vessels are dilated. Clear? So it's very good, Khurshid. Obviously, if you perform splenectomy, most commonly injured organ, it is pancreas. And which part of pancreas? You can cut the tail. Patient can develop acute pancreatitis, you can cut the tail of pancreas. Okay. So these are commonly asked question. Left gastric artery is not there. Okay. Left gastric artery was there. One of the option was left gastric artery. Okay. Left gastric artery was there in the option. Correct answer is short gastric. It is the short gastric. Next. Guys, this question seems incomplete. Patient, known case of carcinoma oral cavity. Known case of C oral cavity presented to OPD as shown in the image below. Likely stage of oral cavity. Can you tell me what is the likely stage? Yes? Very good. So one thing, size is not mentioned, but what you can see here, in this case there is involvement of floor of mouth. You can see the malignancy is involving the floor of mouth. One thing we can see, it is involving the floor of mouth. Let me tell you, students are asking that which stagings are most important for the exams in surgery. Most important, CA breast. Second most important, carcinoma gallbladder. Third, colon and rectum. Fourth, stomach. And fifth, oral cavity. I am repeating guys, 5 stagings. Carcinoma breast, most important. Breast, gallbladder, stomach, colorectal cancer, colorectal, and oral cavity. These are the 5 stagings which are most important. Most important, 5 stagings, most important. Clear? Now see here. Okay, clear? So this is the malignancy and there is involvement of floor of mouth. So let's discuss the staging. Yes, whenever if it is going to invade, see guys, if the patient is having carcinoma lip and it is invading floor of mouth, it is T4A. If it's carcinoma lip, but if it is carcinoma oral cavity and if it is going to involve cortical bone, mandible, maxillary sinus or skin of the face. Clear? So what? It is T4A. It is T4A. Okay, what is T4B? Whenever there is involvement of masticator space, pterygoid plate, skull base, in cases internal carotid artery. Okay, somebody is saying very good, very good. So mass touching lower lip. There was mass touching the lower lip inside the part. Okay, now it's clear. So obviously it's T4A. So obviously it is T4A, guys. So if the mass is there and it is touching, so I'm adding this point, mass touching lower lip. So there is mass touching lower lip. Clear? So if the mass is touching lower lip, obviously it is T4A. Clear? Any other information was there about this malignancy? So mass touching lower lip. Any other information? Bulging below the chin. Okay, it's bulging below the chin. So bulging below the chin. Clear? पूरा माउथ फ्लोर इन्वॉल्व था, ठीक है. If the whole floor of mouth is involved, mass touching the lower lip, bulging below the chin, you can see here, in this case, since up to T3, see up to T3 the size is included. In T4A, cortical bone, maxillary sinus, skin of face, you are saying that chin is involved. Clear? So if these structures are involved, it is T4A, and whenever masticator space is involved, pterygoid plate, skull base, or it is going to encase the internal carotid artery, that is T4B. So what is the correct answer? As per the information provided in this question. Okay, Shailesh wants to say that sir, पूरा बहुत बड़ा सा ट्यूमर था, पूरा ट्यूमर था involving floor of mouth. Guys, whenever there is involvement of floor of mouth, it is T4A. Okay, so correct answer as per the information provided, it is T4A. I am repeating again, you have to remember the staging. Next, very easy question guys, tell me. This is one of the easiest question. Surgeon closed abdominal wall. He closed. Post-contaminated surgery, wound irrigation was done daily after surgery, but skin closed after 5 days. What will be the type of wound healing? Okay, tell me, it is primary intention, secondary intention, tertiary intention. Easy question, tell me. Primary, secondary, tertiary. Primary intention, after incision you just close it. best scar is there, hairline scar is there, that's primary. Secondary, if the wound gaping is there, contamination is there, you just leave it. It heals with granulation tissue, secondary. Delayed primary intention is known as tertiary intention, in which we take care of the wound. When infection subsides, wound contracts, and then you are going to suture it. So guys, this is tertiary intention. Majority of you are correct. This is tertiary intention. Clear? So this is tertiary intention. Okay. Let's discuss what is primary, what is secondary. Healing by primary intention, it is also known as healing by first intention. Primary intention, also known as healing by first intention. Here we have to oppose the wound edges by suture. There is minimal surrounding trauma, best scar. So what you do here, you are going to do the suturing, and you can see hairline scar. Secondary intention, you can see here, this wound is having gaping. Can you see, guys? This wound is having gaping, and since wound is having gaping, you just leave it. So what will happen? The granulation tissue fills the wound and large scar is there. What is tertiary intention? You can see here, in tertiary intention, the wound is there. When granulation tissue is going to develop, you can see, after that you are going to close it. So late suturing is done, and this patient is having wide scar. This is tertiary intention. So whenever wound gaping is there, contamination is there, you do the dressing, you clean it, and after some time you are going to suture it. This is tertiary intention. It is tertiary intention. Clear? So this is tertiary intention. Next guys, ERAS protocol. Let me tell you, enhanced recovery after surgery. What is the full form of ERAS? I am telling you again, it's a repeat question. It was asked in INI-CET only. It was asked in INI-CET only. Enhanced recovery after surgery protocol. Okay. So in this case, what we do here, prolonged fasting is not mandatory, because patient sympathetic stimulation should not be there. Otherwise, what will happen? Yes, there is delayed return of bowel function. We have to mobilize the patient early, and analgesia is must. Clear? Here, minimal fluid loading should be done. Avoid any kind of drain. If you follow ERAS protocol, you can discharge patient a bit early, because patient is not going to develop paralytic ileus. Chances of developing paralytic ileus, it is lesser. So which of the following is false about ERAS? Yes, Shailesh is correct. Only 1% till now, Shailesh. So there is decreased duration, guys. It's the decreased duration of hospital stay. Prolonged fasting, not mandatory, yes. Early mobilization, yes. Multimodal and opioid sparing analgesia, yes. Why? Because if you give opioid, what will happen? It is having anticholinergic side effect, so patient will be having constipation. So that's why correct answer A, because this option is false. This option is false. So it is A. Let's discuss what we do in ERAS protocol. Enhanced recovery after surgery protocol. Counseling, medical screening, optimization, screening and support, smoking and anemia correction, prehabilitation. Then fasting guidelines, yes, to counteract the sympathetic stimulation, we give carbohydrates. Yes, selective mechanical bowel preparation, skin preparation, antibiotic and skin preparation, thromboprophylaxis, and selective premedication. Important problem, fluid loading should not be there. Over and excess amount of fluid should not be given. Otherwise, what will happen? There is bowel edema. It can cause what? Paralytic ileus. Most important thing is, yes, nausea and vomiting prophylaxis. Usually we avoid drain or selected drain. Early mobilization. So see, no nasogastric tube, early oral feeding post-operatively. Early mobilization, multimodal opioid sparing analgesia, fluid overload avoidance, early drain and catheter removal. Guys, so it seems that question was asked from this post-op guidelines. So I am repeating, this is very important, especially for INI-CET ERAS protocol. So no nasogastric tube and early oral feeding, early mobilization, multimodal and opioid sparing analgesia, fluid overload avoidance, early drain and catheter removal. Clear? Shailesh, it is not same as daycare surgery. No, daycare surgery means same day discharge. This is separate. Okay. Now guys, can you tell me what was the exact option in this question? Which of the following indicates acute renal transplant rejection. Creatinine, what was the exact answer? Yes, it is fast track surgery. Shailesh, you are correct. It is fast track surgery, that is known as ERAS protocol. Guys, which of the following indicates acute renal transplant rejection? Okay, in some of the books it is mentioned more than 20%. In some of the literature it is mentioned more than 10%. Clear? So what? Creatinine more than 10% elevated from the baseline. So acute renal transplant rejection whenever the creatinine is elevated more than 10% from baseline. Clear? So guys, these were the questions. Anybody remembers any other question related to surgery? Any other question, guys, you remember? Yes? Okay, let me predict the questions in coming exam, FMG and NEET PG. Because if you follow the last 5 years papers, let me tell you what are the questions which are hot nowadays. Q SOFA. The questions which are hot nowadays, Q SOFA, GCS, yes, pneumoperitoneum. These are the hot questions. Q SOFA, GCS, pneumoperitoneum, Bishop, fast, tension pneumothorax, fast, tension. These are the hot questions. Fast, tension pneumothorax. Clear? A, B, C, D, E, that is primary survey. Burn degree, burn. So it's burn degree or pressure sore or pressure ulcer. Burn degree, pressure sore or ulcer. Okay, pressure sore or ulcer. Okay. Excuse me. Okay, Andrew wants to say that, sir, Zenker's diverticulum was also there. Anybody remembers? Zenker's diverticulum was also there. Anybody remembers the question? Zenker's diverticulum was also there. Okay, yes, that is also important. Zenker's diverticulum image was there. Okay, guys, related to image based question, let me tell you what are the image based questions which are asked. 1, yes, corkscrew appearance, diffuse esophageal spasm. 1, Zenker's diverticulum, claw sign or coiled spring sign. Yes, in intussusception, coffee bean sign. I am repeating, these are the image based questions which are very important. Shailesh, it was not barium enema. In Zenker's diverticulum, we do barium swallow, not the enema. Clear? What are the questions important? Yes, intussusception. In intussusception, claw sign, coiled spring sign. Claw, coiled spring. In sigmoid volvulus, coffee bean. In diffuse esophageal spasm, yes, what? Corkscrew, diffuse esophageal spasm, Fournier's gangrene. So guys, these are hot questions. Fournier's gangrene, every year from just this list, only, every year minimum 2 to 3 questions are asked. Okay, so these are the hot questions. Anybody who is going to remember other questions, please send the questions on my mail ID. Guys, my mail ID drpritesh@gmail.com, drpritesh@gmail.com, or you can send me on Instagram also. You can send that on Instagram also. So on Instagram also you can send the questions. This is my Instagram ID. So on Instagram also you can send the question. Clear? Instagram, you can send the question, right? So we will be giving rest of the questions. Okay, so it was really amazing discussion, guys, with you all. All the best, keep working hard. Definitely you are going to crack the exam with flying colors. Best wishes from the whole PrepLadders family. All the best, guys, all the best.
Sir.